Hello, everyone. Welcome to the Room Now ACR 23 daily recap. It's the final day of ACR, and we have our final takes on what was important. I'm joined by the Room Now faculty who have been working like you can't imagine at this meeting. And then, when I ask them to go out and cover the meeting, I say, have fun, learn something, teach something. And interestingly, Janet and I are in San Diego, but Maral and Richard are doing this virtually. And I think the virtual gig is a harder gig because they don't live stream everything and you got to work even harder to get it. I'm joined by Richard Conway, who's in Dublin, Ireland, Maral El Marahi, who is in Nashville, Tennessee, and Janet Pope, who's from London, Canada. And I'm Jack Cush. We're here in San Diego. I'm from Dallas. Let's get into it. We're going to do two rounds of what we thought was great today, or since it's the last day, we can kind of pull whatever we want out of our hat and discuss what we thought was great and what the audience should know about. I want to begin with Dr. Conway. By the way, Dr. Conway is calling in from from Dublin, and I think it's dark 30, 2 a.m. there. So he gets the Trooper Award of the evening. Richard, go ahead.
Thanks, Jack. Yeah, no, I'm good. I had a little nap, so all good to go. So I'm going to talk about an abstract presented at the Late Breaker abstract session today, which is L16. This was by Lin Yi Peng and colleagues. It was on IgG4 related disease, a study done in China, 146 patients, and they took people with severe IgG4 related disease and the fact that they needed to be on an immunosuppressant and steroids. They were in remission for 12 months at the time of entry to the study, and then they randomized them in an open label fashion to continuing on both the steroids and the immunosuppressant, to stopping just the steroids and continuing on the immunosuppressant, or to stopping both, and saw what happened. This is an important clinical question, of course, because we are not really sure what to do with IgG4 related disease patients who are in remission. And what they found here was you stop both agents, 52% flare in the next 18 months. You stop just the steroids, 14% flare. And you stop, or you continue both, 12% flare. So I think really what this says is that, like many diseases where there's an impetus to stop agents, it's a bad idea to stop everything. You need to continue the immunosuppressions in these patients. But it does say that we can probably stop the steroids. They don't need the combination treatment, but definitely need to stay on something for the majority of patients. I don't think 52% flare rate is not acceptable to me anyway.
Certainly not. What were the immunosuppressants that they were using?
Combination of different things. I think in this part of the world we'll generally use rituximab, but I think China maybe access issues. So there were a number of different things going in there.
Right. That was going to be my question, but I forgot. I mentioned the fact that this is in an area where they may not have access to rituximab. I think certainly does hamper them, and they really even more so have to worry about this. Do these data surprise you, Janet?
No, because I think a better question would be, instead of stopping, what if you taper down a little bit? So it doesn't surprise me that if they needed it, she didn't say how long they were in remission, but a lot of them had been at least in really good disease control for a year or more. So, a patient would ask that, but I think a better question would have been, hey, what if I just lower it, cut the dose in half, go down by a bit? Will they do okay?
Yeah. Maral, do you see many IgG4 patients?
Not as many currently. I would say I have maybe 2 or 3 in my practice. So not as many, but I would say my experience echoes the sentiments in this, is that, you can't withdraw immunosuppressants entirely, but I certainly do agree that tapering the steroids is reasonable. And I agree with Janet that it would have been really nice to see what happens when you taper doses or frequency.
And when you were at the Cleveland Clinic, were there a lot more of these patients?
Yeah, I would say relatively I saw more when I was at the Cleveland Clinic.
Yeah. I have to say, I've seen only one in my career, and I don't know if I'm just if I'm missing them, or I know I've worked up quite a few. But I don't see many of these patients. And I think that when you don't see many, it's even harder to know what to do in the long term after you get control and put them in remission. And the question that I'll pose to all of you is this any different than any other disease we treat? Think of a bunch of diseases that we treat where we have this kind of belief that it may be self-limiting, like PMR, or I remember PAN and GPA being, that's probably self-limiting and you probably stop therapy. Still's disease, reactive arthritis, I can go on and on and on. We have this great hope that many of our conditions that are sometimes labeled as self-limiting are never self-limiting. So I'm never in a rush to, get off of all therapies. I think that's, I mean, patients love it when you say that kind of stuff, but it really is, I think, false hope. Richard, how do you handle this?
Yeah, no, I agree completely. I suppose there's different shades of gray there, but like GCA especially, I think it does not go away. It's always there. I mean, PMR can go away, but it's always primed to come back and cause problems. And I suppose your comfort in stopping agents is going to depend on what's going to happen if the disease flares. So PMR flaring and needing to go back on some steroids is not the end of the world. GCA flaring and you going blind or having a stroke is not great. PAN likewise, something relatively disastrous could happen.
I'll ask Maral and Janet, are there diseases and situations where you really do aim to get patients off of therapy after some point of being quiescent? Maral?
Maybe a burned out RA in a geriatric patient that's had it for 20, 30 years.
Right.
And I'm very convinced that there's nothing. Really, my inclination is more so to taper or to increase the interval of the dosing. And then depending on how they do, I would entertain in that kind of patient population, just because of the risk benefits if there's nothing.
Janet, what's your advice to your fellows on this whole issue of tapering and withdrawal?
Right. Well, for number one, if you stop drugs, they usually stop working. Number two, sometimes patients are smarter than us, so they're non-adherents. They often say, can I lower my dose? And that means they've already stopped it. And then kind of they have. But number three, we all have seen patients, but they're the minority. You kind of remember them that, someone with lupus that was quite bad in 1980s, and now they're great off treatment because they were a one and done, real sick and then better. But we've seen a lot of patients, whereas they go downwards, they flare and we don't always recatch them on the same drug. So that's the problem. So I like, if it ain't broke, don't fix it, just leave it alone.
Yeah. Before we move on, Richard was just talking about PMR. I got to interrupt this broadcast for O Bulletin. And that is, last month we did a campaign on PMR, and Richard is the PMR guy, and we had discussions. I had him on two different webinars. And Richard, I want you to tell the audience your plan for starting steroids, but more importantly for withdrawing steroids, because in a month of a lot of confusion and discussion and opinions, everyone kind of agrees what dose to start, but how to stop, there's a lot of disagreement, and it's a little bit like the art of rheumatology. I thought yours stood out in last month. So again, your plan for starting and weaning steroids with PMR.
So I very much try and keep it simple because I see patients getting constantly confused by our complicated steroid tapers and mixing up their meds, or the pharmacy mixing it up and the patient ending up on some sort of dose they're not meant to be on, and chaos ensuing. So I always pretty much start at 15 milligrams prednisolone a day in PMR, and I do it for a month. And then I cut down every month by a dose of 15 to 12.5 to 10, and then down by 1 milligram a month. I do it on a monthly basis because it's easier for the patient to remember. And in Ireland, at least, the pharmacy gives us a month's supply at a time. So provided the pharmacy do things correctly, the patient doesn't need to do anything. They just take their pills, go back the next month, get another set, take them, and hopefully they end up on the dose they're meant to be on.
Yeah, I throw that out there because I just think it's food for thought. I'm not looking for a big discussion on this because we discussed it all last month and we were running around the block with all kinds of opinions. So it's just for the audience to consider. Maral, give us your big hit for the day.
Yeah, I wanted to discuss late-breaking abstract number 19. So as we all know, the 2020 ACR guidelines strongly recommend intra-articular glucocorticoids injections for patients with knee OA, given that trials have demonstrated short-term efficacy in the knee. So, the question is there any sustained relief of an OA knee that's possible with an intra-articular injection? And so late-breaking abstract 19 looked at a drug called TLC 599 to answer this question, and it assessed the efficacy and safety of this drug in single or repeat doses. So what's TLC 599? It's a liposomal formulation of dexamethasone sodium phosphate that can be injected locally. So this study involved about 506 patients with Kellen grade 2 or 3 knee OA and had 3 different arms. So there was the TLC 599 arm, there was a dexamethasone sodium phosphate arm, and then there was a saline placebo injection arm. So the patients received injections at the study onset and at week 24. TLC 599 was superior to placebo in ADP and WOMAC pain and function after a single dose, with the effects sustained until week 24. They also did do a second round of injections of TLC 599 at week 24 and this showed that it did provide further benefit until week 52. So for me, this was an exciting trial as it helps potentially expand our armamentarium for OA treatment and may be effective for year-long pain relief with 2 injections.
Okay, that's really interesting. And Dr. Pope was the chair of the late-breaking abstract session, and I know you had some thoughts and questions on this, Janet. What do you think?
Right. So first of all, the comparison was dexamethasone, and maybe because the other stuff is a dexamethasone kind of derivative. But the first thing is the placebo was saline. So I asked if there were flares after, and he said some, not many. So maybe they should have given them lidocaine, who knows? The second thing was I thought it lasted longer than you would suspect. Third thing is, depends on what you asked. If you asked about WOMAC pain, the dexamethasone injection or a new study drug injection that has dexamethasone in it were not very different. But if you asked about average daily pain, the drug under study looked to be a little bit better. So I think there were, I think it's promising. It looks like you can give it repeatedly. But I don't know. I think it's going to be a cost differential. And why wouldn't you just compare it to our triamcinolone acetonide, or even a better drug, triamcinolone hexacetonide, and then really know where to put it?
Yeah, I think that this allegiance to, or how you do knee steroid injections, when, how, what you use is kind of like based on the family you were raised by, and that's what you're married to, and that's what you stick with, and the science behind that is nil. So, Richard, do you do steroid knee injections, and what's your preferred agent?
Yeah, I do loads of them. I think one thing about this study, and it's the same as all the intra-articular steroid studies, that really struck the placebo response is enormous. It dwarfs the response to the difference, the delta between the drug and the placebo. So I do loads of knee injections. I think aside from anything else, you're harnessing that placebo effect to some extent. I mostly use depomedrone methylprednisolone, but yeah, for no good reason, just that's the way I was trained, so that's what I use.
Right. And I got to tell you that I've become sort of anti joint injection. I know that's heretical amongst us rheumatologists. We have special skills delivered unto us from up high somewhere on how to do these injections that no one else can do. And we have special fingers, or we have special ultrasounds, and we can do this. And this is like, I don't know, it's a badge of honor. But the fact is, during COVID, we couldn't do any of this. Either you were not permitted, or no one would want you to. And prior to COVID, I was reporting on a lot of studies on joint injections. And you know what? There's no proof that they work beyond the acute period. Now, this study is interesting because Morale points out a 26-week or 24-week and a 52-week benefit, and that's impressive, I got to admit. But I often say the first joint injection I give, long-lasting. You know, the ninth I give is about 9 minutes that it's going to work. And then I worry about, in this particular situation, the long lasting, which sounds like it's benefit, is it not? Maybe it's Achilles heel as far as what it's doing to cartilage, what it's doing to other potential risks and whatnot. I think what I like about this kind of study is it's in the eye of the beholder. Either you're going to love it and run with it, or wait for it to come out, or maybe you're going to buckle down like I am on my views. So, Janet, what's your big hit for today?
So mine's also a late breaker, L20, and I'm going to give you a background. So this is telitacicept, and sorry if I'm not saying it right. So what is it? It's a TACI FC fusion protein, and it's the Bliss and APRIL pathway dual inhibitor. So that kind of reminds us about belimumab and B cell signaling. So the first question, it was an RA study, is, wait, is it the wrong disease? So I will tell you, so this study was performed in China, but they did a phase 3 study in China that they reported in Milan last year in SLE. And I'll tell you, in lupus, don't know if it's generalizable to my patients, but in lupus, systemic lupus erythematosus, tele 160 milligrams compared to placebo. It was a sub-Q weekly for a year. The lupus trial last year that was presented gave SRI-4 sort of double the amount of placebo. The physician global improvement was about 85% versus placebo 56%. It actually looked pretty darn good, even though we don't know the generalizability, the background treatment always on the lupus population. So this one went on to say, let's look in rheumatoid arthritis, large randomized controlled trial, double blind, methotrexate inadequate responders. I'll remind you, number one, the often methotrexate, it only had to be 7.5 milligrams per week or more. In China, they tend to dose it less than the US. So I'm not sure what the mean dose was, but it was probably far lower than our contemporary FDA kind of trials because of a different population. The other thing is the ACR responses and the change in DOS were in general statistically significant, in general clinically relevant, but in general a little bit disappointing compared to what we think a drug coming to market would be like. If we were looking at an IL-6 or a TNF or a JAK, we'd think an ACR 20, 50, 70 of maybe about 60 or more for the ACR 20. ACR 50 is about 40%, and ACR 70 about 15%. So their numbers were blunted. However, someone did ask the presenter about it, and she had a great response. She said, since we didn't have an active comparator, it was methotrexate IR, adding placebo or adding the telitacicept drug, you don't know how would maybe an adalimumab arm would perform. Number one, we don't know. Number two, I was impressed that the X-ray changes looked very similar to me, like trials that we would see that would be blunting the X-ray progression in a fashion that is similar to other drugs I've seen. So I'm not fully impressed with the results. Is positive, but it does indeed look like a DMARD. And so in my mind, I thought maybe this is something to use in lupus, the RA lupus overlap patients, because that's why I presented the lupus stuff first. The lupus, in lupus, I'm quite impressed, but in order for FDA to ever approve it, you got to have a US population being studied.
Maral, what do you think of this research?
Yeah, I agree. I thought it's like the one thing that comes to mind to summarize it is ellipses, ... I thought there's promise in it. I think that the target population for me, I would echo Janet's sentiments on that, would be a lupus patient. But I'm excited to see more studies, especially an active comparator trial.
Yeah. Richard, would you put this in an RA patient?
Yeah, I don't know what to make of the study. I keep going between thinking it's great and thinking it's not so good at all. Like, you look at the ACR 20 of 60%, you think that's actually decent enough. And then the ACR 50 is only 20%. At the same time, the placebo ACR 50s are 5% or something. So it's very hard to know what to make of it. And I think we probably do need an active comparator trial of some sort to know where to place this.
Yeah, I don't know why. I just seem to see red flags, and a drug like telitacicept has now appeared in the last few meetings as being incredibly effective in lupus, in RA, and in Sjogren's syndrome. And I don't know about you, but my treatment of lupus, RA, and Sjogren's is not very similar at all. And I think the biologies and manifestations and range of what goes wrong there. But the good news is it's early, and congratulations on your success. Now let's see what happens when you can put it into a lot of patients and hopefully do a multinational study. This is similar to the results we had with the TLL-018 combined JAK1 TYK2 inhibitor, also from China, that had this incredible results that we reviewed back in EULAR. I think it might have been reviewed yesterday, but the idea is that combined JAK-TYK inhibitor was as good as tofacitinib, and then in the 2 highest doses blew tofacitinib out of the water. Crazy numbers, like 70% responses when tofacitinib was only getting 40%. And there was no placebo. It was a active comparative control. But both these studies suffer from being done only in China and producing incredible results. So again, they can make our skepticism go away with repeat data in a more diverse cohort. Mike, one I just want to briefly mention is an analysis of the Paisley study, looking at, in this case, both the skin manifestations and response to deucravacitinib, a TYK2 inhibitor, and also the relationship between the alpha interferon signal and drug response. So Paisley was previously presented as a phase 2, and in this study they do a sub-analysis of patients. Looks like it's about, I'm going to say, I don't know, 75, no, about 100 or so patients who had active skin disease, and as measured by the skin standard there, the CLASI score, which had to be 10 grading in, and really they showed some very impressive skin responses. And I think that's highly encouraging. In fact, when I'm advising companies who are developing drugs for lupus, I tell them, big mistake to go after a global lupus response with a SLEDAI going in and an SRI-4 coming out. Often those trials exclude nephritis, and it may work. It usually has a high placebo response, and then you don't know who to use it to if it gets approved. If you go after organ-specific responses, like in this case, is skin only, a cutaneous lupus clinical trial, it's brilliant. We have plenty of cutaneous lupus to manage, whether it's DLE, SCLE, or acute LE. But anyway, they showed really good responses, 50% reduction in CLASI at week 48, and somewhere between roughly 50 and 71% of patients. Total clearing by CLASI score at week 48 was roughly 20 to 30% on the 3 doses. That was all good. And then the other part that they showed good pictures, which were impressive. And the other part that they showed was that if you looked at SRI-4 response by whether or not you had a high alpha interferon signature versus low, you had better responses with the usual indicated dose, 3 milligrams BID, in those who had a high alpha interferon response. And that's what they're purporting to be one of the mechanisms by which TYK2 inhibition may work in lupus, is it's going to ultimately affect the interferon signal. So I think this is a nice, clean sub-analysis. They have other trials in progress, but we're going to have to wait for those. Anyone have a strong feeling about this?
Looked good. I liked it.
Okay. Maral?
Yeah, I can't remember if they showed you the subtypes of the cutaneous lupus, and if they gave you a further analysis as to what the response was.
I want to say there was a slide on that, but I think the numbers were too few to delve into acute versus chronic LE, for instance. Okay. So I don't think that was going to be their take-home message. I would hope that they're going to write this up and provide that kind of detail. Richard, are you using JAK inhibitors at all in lupus?
I am not so much anymore. When the early baricitinib data was there and looked good, I went through a phase of using them, and then the phase 3 data, or the later data, did not look so good, so I kind of stopped a bit. I've become very pessimistic about drugs for lupus, and that we see these excellent early data for lots of agents, and then it just doesn't seem to work out when they get onto the later studies. So I suppose we'll be cautiously, slightly optimistic, but not fully convinced yet.
Yeah, the pattern is everybody's a hero in phase 2 and a bum in by the time they get to phase 3. But think of all the literature has come out since we've seen JAK inhibitors since 2012. And there is a steady stream of cutaneous success with the JAK inhibitors, whether it's, I'll say GVHD, that's much more than skin, but dermatomyositis and all atopic dermatitis and the alopecia variants, and there's more to come. I mean, it's pretty, vitiligo. It's pretty impressive, and so much so that I'd say that's the home run if you're developing a JAK inhibitor in lupus. But right now, as best I know, there's only one company that's out there that is working on a JAK inhibitor for dermatomyositis. So we'll see where that goes. All right, our next round, we're going to do shorter presentations. Let's begin with Maral and see what you got.
All right, I really liked late breaking abstract 18 because it may help guide treatment of primary Sjogren's syndrome through molecular classification of salivary glands. This study entailed transcriptomic profiling of salivary glands in a Chinese cohort, and it did discover 3 distinct subtypes. First subtype is a POSI immune or C1 subtype. The second subtype was a cold immune or C2 subtype. And the third subtype was a hot immune or C3 subtype. So it showed that the cold immune subtype involved activation of the classical adaptive immune system, and it showed depressed metabolism, whereas the hot immune subtype involved activation of the innate immune system and had active metabolism. They did also show that the cold immune subtype had a higher risk of lymphoma. So overall, I think this molecular classification of salivary glands helps guide understanding and the heterogeneity of the disease and can help guide further treatment. I would like to see studies hopefully maybe incorporate this, and maybe we would see more positive studies for Sjogren's treatment.
It certainly is a smart approach. How many people did they look at overall in this as far as their lip biopsies?
Let me see if I have that. So 396 had primary Sjogren's syndrome. So total, I think of about, if I do the math really quickly, about 500. 398 had primary Sjogren's syndrome, 87 were non-primary Sjogren's syndrome, and 44 were early primary Sjogren's syndrome.
And they all had lip biopsies?
Yeah.
Wow.
Impressive. I know that might not be as common here, but
that's an Academy Award winning abstract as far as effort and histology and making correlations. And I think that should be applauded. And I'm often not applauding Sjogren's research because it's mired in so many things, but this makes something confusing into something that's quite clear. Janet, what did you think? You were there.
What's cool is I think AI will help this in future, and you'd want to know on these subtypes. My guess is they'll have different responsivity to drugs, but it might not be to specific drugs. It could be to all drugs. In a way, the fibrotic phenotype in RA on synovial biopsy is myelofibrotic is not a very good response. They're kind of a bit. They're probably that ceiling effect that we never get, everybody in an ACR 20. So I kind of wonder if I would guess the cold one, but I kind of wonder if one of those sets is going to be possibly a non-informative patient and for drug development.
Yeah. All right. Well, yeah, where all the futility will be met and none of the responsiveness. Richard, do you get lip biopsies in Sjogren's? I do not.
Not as a rule. I seronegative Sjogren's, and I will occasionally do it. It's hard to get it here. High complication rate, a lot of paresthesia post-it, which can sometimes be worse than the symptoms you were doing it for in the first place. So rarely, but I do occasionally.
Okay. All right. Janet, you have a second one for us?
I do. I have two really quick ones because in my mind they're a pair. They weren't presented together, but it's the clinical question here in systemic sclerosis is who will get ILD and who will progress ILD? Because I think every clinician wants to know that that's treating these patients. So abstract 1700, it was an oral. It was looking at the big U-Star, that's the big, large conglomeration of multiple countries contributing scleroderma to the database. So there were over 5,000 patients. And what it showed was that if you had a negative HRCT at baseline, over time, who will get ILD? And it's almost like a flat line of incidence over time. There's a little bit of variability, but the idea was always the old-fashioned clinical wisdom is that if you don't get it in your first couple of years, you're probably home free and the incidence goes way down. This is showing not the incidence in the first year or two, because if you already had a positive HRCT, you're out. But if you didn't, you can get it anywhere along the way, and they went up to 10 years. And the risk factors were the ones we know: men more than women, topoisomerase 1 positive more than anti-centromere or RNA polymerase 3, little bit of elevated CRP, and probably age as well, although age was hard to know. And then obviously dyspnea. Well, dyspnea is related to getting ILD, not a risk factor for ILD. So that was the first one. The second one was another question. Okay, who's going to progress? If I have patients in my scleroderma clinic and they have ILD, who's going to progress? So in this one here, I'm trying to find the number. Sorry about that. The number, I'll find it in a sec. But this one was looking at two large databases combined from two sites in Europe. And it was number 643. And what they asked was, if you have progressed enough that would have gotten you into a randomized controlled trial, such as progressive pulmonary fibrosis, the Census and InBuild trials for nintedanib, there's many ILD trials. So they looked at the inclusion criteria. So if you were a progressor now, looking over the last year, what was your chance of progressing in the next 1 to 2 years? And guess what? No prediction at all. People who didn't progress before then progressed. People who did progress didn't. All over the map. And in fact, it was almost protective next year about progressing if you progress this year. So it's kind of, I think we have to beware. I know. So in other words, trial design has said, put in only early, diffuse with lung disease. So the one abstract kind of negates that. Then they also have put in people enriching the cohort for people with ILD already progressing, and they don't all. However, think of it in RA. If we have an RA RCT and people have active disease coming in, even a high CRP in some of these trial requirements, only 8 to 15% actually get erosions in the next year. Maybe that's the very same with lupus progression, because these are true progression. And the stricter the definition, the smaller the N. So anywhere from 19 to 30% approximately progressed over the next 1 to 2 years by progression criteria. So I think we have to beware as a clinician, know that ILD can occur, ask about symptoms, auscultate, periodically for sure do PFTs and do an HRCT where indicated, number one. And number two, once you progress and we treat, they might level. I always say it's like an escalator. It's not an elevator going straight down or a ramp. You progress or you're level, then you maybe aspirate or get COVID or something, get an infection. You progress, then you level, then you progress. So within an individual, it's not a slope. It's a series of line, stop. And we have to remember that. So it's important for the clinicians.
Yeah, so that's instructive in that disease management becomes key. Advice becomes key. One of my favorite lines to patients is, the goal is to be boring. Find that which works in a treatment regimen, a lifestyle, a follow-up, a lab thing. Be boring. And the more boring you are, the more you're going to stay on that ramp that's not changing, and you're not falling off, as you're describing here, by life's events. Some of that's going to be unavoidable, but that's instructive in a cohort that's really difficult to manage longitudinally, especially. So, Richard, your quick hit.
So my one was a study by Peter Taylor presented today, 2586. This was a new blood-based test in rheumatoid arthritis. We're using plasma and looking at cell-free DNA, and that was synovial mapped. It always sounded a bit complicated and maybe a bit expensive, but the results were very impressive. So we know seropositive RA, we have tests for that, that's fine. What was really interesting here was seronegative RA. So this test had a sensitivity of 84% and a specificity of 95% for seronegative RA. And I think that potentially is incredibly useful to us clinically.
Give me those numbers again.
So a sensitivity of 84% and a specificity of 95%.
And what is the test against? Or is it one antigen or peptide, or is it a series of things?
It's not one, as far as I understood it. It's looking at this cell-free DNA and synovial mapping signatures, and then using machine learning with the results to spew out this number.
This isn't the joint ID study, is it?
The which?
He didn't call these joint IDs? No?
No, I don't think so.
Okay, there was another abstract at the meeting about developing an autoantibody, looking for autoantibodies against joint peptides, and that finding certain joint peptides could be predictive of future remission. I played with that a long time, looked at it a long time, but in the end, I don't think that it had enough punch of predictive value. What you're talking about has tremendous predictive value in a troublesome group, that 20-30% of patients you follow who are seronegative, and who are they really? This seems like it might unify some of those people. That's interesting. Very interesting.
I was just going to say, I could say where it would fit in is once you fail first and second line advanced therapies, you know, if they're PSA without psoriasis, maybe they'll get an IL-17 or something. If they're RA and seronegative, maybe a test like this, you'd say, okay, I'm going to go on to a different drug that's in an RA sphere. Who knows, right?
Right. That would be the next step, right? To see if he can find a large cohort of people taking many different medicines and responders and non-responders, then come up with some strategy as to what you wouldn't want to use and what you might want to use. Boy, that would really help a lot of us people who are taking care of these folks, as Dr. Taylor and others are. So that's very cool. My last one is abstract 2480, it looks like, from Conzit et al., Victoria Conzit, who's with the Vienna group. Smolin and Ali Taha is the senior author on this. And they took two different data sets, one, the NORD-DMARD data set, and tested, developed criteria for flare on 80% of those patients. And we're going to then validate it in the other 20%, and then also validate it in the Vienna RA cohort, which is almost 2,600 patients. And in the NORD-DMARD study, they asked patients, how are you today on a 5-point scale? I am much worse, unchanged, better, much better. And a flare was said to be a 2-class change in status. And then they backworked their numbers and came up with a cut point for what constituted a flare on CDAI, which was 4.7, and on, SDAI, it was 4.7, and on CDAI, it was 4.5. And they made other correlations which were important and looked good, and they showed that patients who met this criteria were also shown to have functional consequences to such a flare, and even radiographic consequences to such a flare. So it's a kind of metric PRO correlate kind of study, not my cup of tea, but you know what? They really put a number on flares. And I think this is one of my pet peeves in rheumatology, especially in RA. We all treat flares, and you know how it goes. It's a note from the patient, a call from the patient, and you write a prescription for prednisone or they come in and they get an IM injection, or they get some new dexamethasone intra-articular thing that's going to last for 9 months. You hope, but it's all steroids all the time, and that's the cha-cha-cha dance that you do, and there's no science to it, and there's no rationale to it, and it's got built-in toxicity. And why can't we use, in, I don't know, a type B2 patient, I just made that up, colchicine, or in a type E9 patient, a short course of anakinra, or, let's get some company to do some clinical trials in patients with RA who are flaring, and use your active comparator, gold standard, as steroids. You've got a built-in toxicity index that you got to win at no matter what you're doing, right? And I would think, I don't know, can't say that's a certainty, but it certainly makes sense. So I think it's an advance. I think it's an advance to people developing therapies. I think it's an advance to people who want to study this issue, as I hope many do. Anybody have a magical formula for flare management?
I think it's what you said. And I mean, in the catch cohort, we validated the flare, the EULAR flare questionnaire or index, and half of the patient's flares we think aren't, number one. And number two, when it's a very major flare, there's a lot more concordance, of course, because when they feel badly and we don't see anything, we tend not to believe them, and then we might change their treatment. But if you're doing it on the phone, you just say, okay, we'll phone in the prednisone, and we usually ask, well, they're flaring about adherence. Are you even taking the drugs, right? Because it's hard to be, it's a bit of a ball and chain. It's hard to always be 100% adherent.
Gray hair allows me to tell a story that's, we hope is real. And that is, when I was a resident, I went and did a extended rheumatology rotation at the University of Pittsburgh with Gerald Rodman and Tom Metzger, who are heroes of mine. No nicer man in the world than Dr. Thomas Metzger. And when I did rounds with them, they had an inpatient unit, a rheumatology inpatient unit, and they would admit patients with active disease and flares. And know what their treatment was? Bed rest. That's it. Bed rest and analgesics. They didn't want to give steroids to them. They sometimes had to give steroids to them. But if they just put them on total bed rest, and that means bedpan bed rest, no walking, no talking, no having fun, you know what? Their SED rates and CRPs came down. Their swollen joints got better. And I just say this because it doesn't have to be just steroids. And again, I think that this research allows for these findings and these new cutoffs allow for further research going forward. All right, that's enough for our final recap of ACR 23. I want to thank Drs. Conway, Pope, and El Ramahi for this great discussion. Tune in and follow our topic podcast, which will be coming up very soon. You'll get a topic recant of what was hot in areas like lupus, RA, spondyloarthritis, psoriatic arthritis, and JAK inhibitors in the days to come on RheumNow. Thanks very much, everyone. Happy ACR.